Wonderful. You'd have thought 2 years into this pandemic and Zoom would be second nature to us all, so I apologise, but we're getting there. Okay, so obviously we're on Zoom rather than a face-to-face, but nonetheless, hopefully you'll be able to get a sense of what we're doing. If you've got questions, if you've got ideas or things you want to share, then that Q&A form at the end will be obviously a space to do that. Now, what I wanted to talk about was prematurity, and not just prematurity, but early life adversity. And not just looking at the things that are challenging, things that have gone wrong, but actually what can we do about it? Because that's where it really gets exciting, is not just saying that, sure, there's a problem, but how can we fix it? How can we help? How can we make a difference? And to me and to my team, the work that we do, it's all about trying to understand a problem so that we can understand how we can help. So you'd have to live under a really big rock to not be sort of aware that across social media, all sorts of different platforms, there's this notion that, you know, as women, we become pregnant at a time of our choosing. It just happens. It's great. And once pregnant, we get bigger and fatter and rounder. Everything just boxes on. It's all fine and gorgeous. And we bloom and the baby grows and we feel fantastic and it's all perfect. And then at some point, 40 weeks after point of conception, a baby is delivered to a healthy mum, and this healthy baby goes on to live a fulfilling, normal, beautiful life. And whilst that is undoubtedly the case for many, and that's certainly what we strive for, there are many, many instances where things just don't go to plan. And it's really important that we acknowledge that when things don't go to plan, we need to be able, as a society, as a bunch of clinicians, to do something about that to help. So Time magazine, I think, put this cover out a couple of years ago now, and that really just reinforces that across not just medicine, doctors, nurses, but the wider community are becoming more aware of the impact of preterm birth. And so WHO and others have come out and said that prematurity now represents a global health crisis and an unsolved clinical challenge. And that still remains the case. We know that preterm birth is common. We know that babies are affected throughout the globe. We know that they have issues with their long-term health and well-being. We know lots about how to care for them in a NICU. We know lots about all sorts of stuff. But despite all of that, there are still gaps in our knowledge and there are still opportunities for us to do things better. So trying to quantify that, we know about 15 million kids around the world are born premature each year. That's a phenomenal burden of prematurity. We know that preterm is still the leading cause of neonatal death. So kids are dying just because they were born early. That's huge. And we also know that health and well-being is directly impacted by your gestational age at birth. And that's not fair. You know, the fact that you were born 26, 28 weeks gestation rather than 40, the fact that that impacts you right through your childhood, through your adult life, we need to do something about that. So when we think about the neurological cost of all of this, these images of brains we've got down at the bottom there, we can see that if you're born at an extremely preterm gestation, so 28 weeks or below, the brain is this really simple structure. It's a little wee peanut, very, very smooth. And it's quite small, you know, as you'd expect in a very small person. And then between that preterm right the way through to a term-born baby, that brain not just grows in size, but it grows in complexity. It's getting more and more complicated. It's trying to do more and more things. And in the optimal setting, that all that development happens as a fetus. But when you're born too early, all of that complex development has to happen in the postnatal world, where things are much more challenging than they would have been had you stayed tucked up in utero. And so again, another magazine cover, again, the message getting out there to the wider population, that this actually matters, that the first 9 months, well, the first 1,000 days, first 3,000, 5,000 days, really shape your trajectory for well-being through the rest of your life. We used to think, as neonatologists, that if you had a very pram baby and essentially got them through all those early challenges, which can be huge. And I'm not underestimating for a moment the impact that life in a NICU has on the child, on the family, the siblings, the wider whānau and community. But Once we've got through that, we used to think that this child was then pretty well discharged and for the most part able to go on and live a life that was no different to many other children. What we know now is that there's this concept DOHAD, developmental origins of health and disease. So things that have happened to you from the time of conception or even prior to conception, through pregnancy and through that early postnatal life, really impact the rest of your life course. And they set and train a trajectory of well-being that is pretty much hardwired or might not be. So if we look, and just sort of, this is a very, very gross simplification, so bear with me, but we take here, it's a point where you're born at full term, and then this is age going through into middle age, older life. And up here, this is the risk of disease. So we know that as we age, you know, it's not just your hair going grey and everything else starting to get a bit dodgy, but things like heart disease, neurological disease, all sorts of other problems, metabolic disease become more prevalent. If you're born prem, your trajectory starts from a completely different place. So right away, your risk of having disease is higher. And as you age, that risk amplifies over time. So you're different. You're different by merit of your gestational age. And that's not great. We know that if you intervene later in life as an adult, sure, you can move that trajectory a little bit. You can reduce the difference between disease risk in a prem and a term-born person by a bit. Not a whole lot, but some. But then if we intervene early, so we're not going to change that line right back to how it was for somebody born at full term, but we're going to change that trajectory from the preterm line and bend it so that it's closer to that of a term-born person, which is going to make a significant difference to your disease risk. So you drop the disease risk overall from way up here to something more approximate to the risk experienced by somebody born at full term. And that's because when we are young, so in that periconceptional pregnancy, sort of fetal state or early postnatal life, our bodies are designed to be plastic. They're designed to be able to adapt and overcome things. And as we age, we lose the ability to adapt. We just become set in our ways. And the body's capacity to absorb change, to figure out new ways of doing things, becomes less and less. So we really need to harness that plasticity and to optimize everything we possibly can here in this early life space, so that if you're born prem, okay, we can't change that. Your gestational age, it is what it is. But what we can do is we can change the shape of that line, that trajectory, so that as you age in a healthier way. And that plasticity gives us opportunity to make a difference and to give these kids a better chance. Oops, there we go. So when you think about, particularly for a preterm baby, what they experience, their world is very, very different. And any of you that have set foot in a newborn unit or have been affected either personally or through friends, colleagues, whoever, and have seen even images of a newborn unit, you know how different it is. Everything is different. So baby, you know, a fetus, 28 weeks, 30 weeks, should be tucked up, nice and cozy inside mum. Thank you very much. Just boxing on. If that little person needs to be born early, suddenly all of the amazing things that mum can just do have to be replaced by machines, by technology, by kit, doctors, nurses coming in, doing, fiddling, sorting. And all of this to try and replicate in some way or other what just happens in a healthy pregnancy. So from a sound, light, touch, metabolic balance, fluid balance, hormone exposure, everything is different. And you can see that very clearly here. So both of these little people are 24 weeks gestational age. One's tucked up quite happily in mum, and the other is one of my patients. I'll just point out here, there's a number of pictures of children throughout this presentation. These are all images that parents have been kind and generous enough to share with me, specifically for the purpose of sharing with a wider audience, so that we as a community throughout New Zealand can start to understand what preterm means, so that we collectively can come together and actually try and do something meaningful to help these children. So these are very real kids. These are kids that I've looked after, and it's been my very great privilege to work with these families, both with these children as newborns and later on as well. So we've sort of thought about, okay, prematurity. We understand that the ex-utero environment is very different for these kids. But if we want to do something, we need to understand that legacy. We need to really quantify what is different amongst children born prem. And this bench to bedside notion, this is really or the notion or the construct that my research groups are founded on. So we work in a number of different spaces, so community and policy, translational biomedical research, and clinical innovation. Oh, sorry, a bit trigger happy there. All of these different facets intersect one with another because a clinical research space informs what we do, both in the community and policy space, but also creates the research questions that we then try and answer. Information gained in either of those spaces feeds directly back into clinical innovation. So our group works across all these different domains so that we can make sure that the questions that we're asking, the information that we're gathering, is actually going to make a difference. Because clearly, having information for its own sake, whilst that might be fascinating, it's not actually going to give us a step change in what we can do to help. Okay, so quantifying what this actually means. So that's Neville up the top there, Neville Pearce. So he's a fantastic dude that actually really understands these big data sets and understands epidemiology, public health, and that out there in the community, in the real world, what's going on. So it was a conversation with him to say, well, okay, our premies, within contemporary New Zealand, within the health service that we've got, what actually happens to these kids when they leave the unit? We know lots of stuff from the international literature, and that's great, that's a place to start. But what about Kiwi kids? What happens here? Because our healthcare systems are wildly different to the NHS, wildly different to North America. So whilst we can look at their experience, it's not actually relevant for what's happening here in New Zealand and in contemporary New Zealand. So what we did was decide to look at a couple of birth cohorts. So we looked at children born, I think it's 2005 to 2016, and this is every live birth. And there's a whole slew of clever ways in which we were able to gather up that data. And we wanted to look and see what were the survival rates of these children, and not just as newborns, but out to 10 years of age. Once they left the NICU, what was the overall sort of quality of their health? Do they have to come into hospital all the time? What was going on with them? We wanted to gather up the before school screening tests. So those of you that are parents, presumably familiar with this, this is just a generic screen that actually looks at school readiness. So hearing, vision, neurodevelopmental or behavioural issues, and general health and wellbeing. And then when these children are at school, what about any special interventions they need with reading recovery or special supports within the classroom? And then we also wanted to look at a slightly older cohort. So these children were born 1998 to 2000. We wanted to see at NCEA L1, so when these kids were 16, how were they? What was going on in terms of their ability to engage with sort of school curriculum and so on? Just as a very crude measure for overall, how were they doing? So first of all, this is the survival data. And what I'd like to point out is that for a preterm baby born in New Zealand, you've probably got a better chance of surviving here than pretty much anywhere else in the world. So even our tinies born at 23, 24 weeks gestation, over half of them survive to age 10. Some of the European data from the same time frame, survival rates for those children were less than 20%. So our kids are doing well. And you can see there very clearly that week by week, as gestation is more advanced, survival to age 10 increases. So when we first looked at this data, the point was raised, well, it's all well and good these children surviving, but what is the quality of survival? You know, are they well, or are they children that are really struggling out there in the community? So the first thing we did was look at hospital admissions and to see whether or not they were having to come back in and out of hospital frequently. And what we can see here now in the next few graphs is on the x-axis at the bottom here, we've got gestational age at birth. We've just grouped them into 2-week groupings, and term is the bright pink down here. So all the comparisons are made against this term cohort. And you can see that, you know, as one would expect, if you're born extremely preterm, you're more likely to be readmitted to hospital in your first year than somebody who was born at full term. But it's not just the extreme prems that this is true for. It's right the way through that gestational age continuum. So even 33, 34, even down to 37, 38 weeks, they behave differently to a child born at full term. So clearly this is telling us something really important about gestation and how any reduction in gestation length actually has an implication for overall wellness for these children. We looked at the before school data to see whether or not, or what parental perspectives were by the time these kids got to 4 years of age. And again, 39-40 down at the bottom here, this is our reference group, because we've just compared everything to a term-born child. And the way that this is constructed, it's, do you have 2 or more concerns about your child's well-being? 1 concern, a non-significant concern, and that's parental definition, or no concerns at all about your kids' overall health and well-being. So even amongst our cohort of babies born 23 and 24 weeks gestation, half of families reported they had essentially no particular concerns about their child's progress, which when you think about it is remarkable. And yes, there are these issues down here that are important and we need to think about. And again, there's this dose effect of gestational age. So compared to our full-term group, even a small reduction in gestation length, and we start to see an increase in the concerns parents have about their child's well-being. So gestation matters not just for the extremes of gestational age. And similarly with the before school check, we also looked at hyperactivity scores. So as a very crude measure of things like ADHD, so sort of busyness, you know, a child's ability to engage and concentrate on a particular task. And we can see extreme prems right the way through to close to term, still having generally, they're more active, busier, more hyperactive than a child born full term. And remembering this is at age 4 years. Mental health, something we think a lot about. So we looked at both inpatient and outpatient psychiatric care. So this is now specialist level care rather than GP-led care. And again, saw that there were differences by gestational age. So again, just telling us something, giving us another sort of facet of this child's overall well-being. Then in that older cohort, we looked at NCEA and saw for even this group here, sub-28 weekers, bearing in mind this was a population born 1998 to 2000, so a very different era of neonatal intensive care medicine. But even despite that, the majority of these kids were passing NCEA, although the scores that they got were impacted by gestational age. So clearly there is still work to be done in this space. But when all that is said and done, we need to come back to our patients. So this wee dot, you know, we have to just keep coming back to who are these people? They're not just numbers on a spreadsheet. They're not just points of data. They are people in their own right, with their own story and their own lives. So this little lass was born 4 months early and 465 grams when she was born. So you can see here, there's her hand, her arm, it's her chest, her face, and we're just giving some help with her breathing with this face mask over the top. Tummy down here and a little leg down here. So when you think of, you know, block of butter in your fridge, that's 500 grams. So she was less than that. And here she is now, taking the cows home. Thank you very much. Boxing on, loving life, and clearly thriving. Similarly, young Jerry, born at 23 weeks gestation. So really right on the cusp of what we can offer in an intensive care setting. 600 grams, still a wee dot, still needing a huge amount of help. And you can see he's needing help with his breathing. He's got tubes for giving him food, for measuring blood pressure, for giving him medicines, completely dependent on that neonatal intensive care environment. And here he is now. So a year or so later, and he's doing his best Picasso. So yeah, he's doing great. And that's why, yes, these data sets are important, of course they are, but particularly in this field, we need to keep going back to the children, to the families, the communities that we're looking after, and the impact that neonatal intensive care can have. But we also need to use that data to keep asking ourselves, can we do more? Given that there's all these different which ways in which their environment is wildly different between a fetus and a preterm baby, can we improve anything? Can we improve the cardiovascular medicines that we give? Can we improve the breathing support? Can we do more to support brain development? You know, how do we continue, not rest on our laurels, but instead strive to get it better and better and better? And that's where that translational component comes in, because we've got to do our working out in a safe space. We can't work things out on someone's child. That is just wrong. So we need to come up with a better way of doing it. So what we've done here is work out that actually premature guinea pigs share pretty much all of the key features that we need to think about in terms of metabolic status, cardiovascular status, and even brain development, so that we actually now have a really, really good animal model to help us figure out, sort of at a cellular level, at an organ level, what does prematurity mean? And therefore, what can we do to try and mitigate or to reduce the consequences of being born early? So what we've done is develop a guinea pig intensive care unit. You can see the incubator here. It's one of the older ones from the NICU that they very kindly let us use. So we can basically give our premature guinea pigs the same level of breathing support, nutritional support as we'd give a baby born at 28 to 30 weeks gestation. Right down to nutritional support. So we have to hand milk these guinea pig mums to get the colostrum in the milk because their preterm pups can't suckle. And every hour or 2 hours, day and night, for days and weeks on end, we sit there and we drop feed these preterm guinea pig pups, so that by the time they get to term equivalent age, they are up and about, they're able to suck feed off their mums, they're bonded to their mums, and we can actually then start to figure out how do we optimize their well-being through the rest of their life. And we're able to do that because it's not just the care that the preterm pups get, but we're also able to look in a lot of detail throughout the pregnancy. So prior to mating, during gestation, we can do these really detailed ultrasound scans, for instance, and look at fetal growth, monitor all the things that a pregnant woman would have monitored, so that we really understand exactly what is going on, so that any research findings, any recommendations we make are based on really robust, scientifically valid evidence. And that's important because, of course, the conversation between a mum and her unborn baby starts really early. You know, from the point of conception, there is a conversation happening between that mum and that baby as it grows and develops in the womb. There's information that the fetus sends to its mum. There's information, there's nutrients, there's all sorts of stuff that mum gives the baby, and the placenta, of course, acting as that interface between the two. That's also doing a huge amount of signaling and control and coordination between the mum and the baby side. And this just is an incredibly complex, incredibly clever sort of balance that makes sure that mum is able to thrive and the fetus is able to thrive, grow and develop in the way that we want it to. So understanding that, then one of the things we are curious about is, how does maternal diet impact fetal development? because we know that diet's really, really important. We know that the fetus basically has the same nutritional environment, or mum's diet regulates the nutritional environment of the fetus rather. So how do we make sure that the fetal nutrition is as good as it possibly can be? So this is Shana Coker. She's one of my PhD students at the moment, and she's interested in the question of vitamin C, because it turns out that vitamin C actually does all sorts of really, really exciting things in brain development and all sorts of other stuff as well, that certainly I didn't appreciate when I was pregnant with my kids. I kind of wish I had, but a bit late for that now. We also know that low vitamin C levels are really, really common. And 20–25% of pregnant women will have low vitamin C levels. Not terribly low, so not sort of giving you scurvy or those deficiency state, but just at the lower end of normal. And the question is, well, does that matter? So she's done some really lovely work where these guinea pigs are randomized to either a low vitamin C or an optimal vitamin C diet during pregnancy, also prior to and during pregnancy. And then once the pups are born, they all go onto an optimal vitamin C diet. So we're just looking at fetal exposure to see what difference that makes. And we can see very clearly that if you change the diet, so the red one here is the low vitamin C diet, green is the optimal or normal vitamin C diet, that both in blood, but also in brain itself, vitamin C concentration falls in response to the diet that you're on. So then sort of there's a big so what factor for the babies. So what we've done is basically it's a neurodevelopmental assessment. So the guineas go into this box, there's a GoPro camera mounted over the top, and from on the other side of the door, we can just see what they do during 10 minutes of ambling around in this box, with or without other things for them to investigate. And we can see whether they're busy or just quite happy and chill, as a way of measuring sort of an ADHD type behavioural pattern. So you can see down here on the left, there's a guinea that sort of came in the box, sort of sat there and went, oh, this is just a bit tedious, nothing much doing. Versus this little one who went into the box and sort of was scooting around, exploring, wondering what was happening next. So we can measure the distance they travel, the speed, their exploratory behaviour, all sorts of things, and make some inferences about that. And the first thing that she found was that actually vitamin C during fetal life makes a difference to neurodevelopmental outcomes. So we can see green here is optimal vitamin C, and the red is a low vitamin C. So between birth and 25 days, this is sort of young childhood equivalency. Even though these offspring have been fed an optimal diet, their fetal environment regulated the behavioural state as they grow up. So this is the start of what's going to be a really exciting body of work. But to me, this really, again, emphasises how important it is to understand maternal environment, so that we can understand for the child what's going on. Then Alice, who's one of my other PhD students, so the Neurological Foundation are actually funding her PhD scholarship. And just go back to what SJ was saying before about support for the time of COVID. Obviously, Alice's work has been massively impacted by COVID regulations. So thank you to the Neurological Foundation for supporting her through all of this. What she's interested in is a thing called creatine. So not in the way that bodybuilders use it, but creatine as the thing that really provides the energy, the power pack for your cells. And we know that as a fetus, you're really dependent on this creatine. You get it from your mum, you get it from the placenta, and we think that that just tops up all the fetal cells so that they're able to withstand all the challenges of birth, labour, and so on. So we wanted to really get into this a bit more and see whether or not for babies that ended up being born preterm, whether creatine could in fact give you like a sort of safety buffer from a cellular energetics point of view. So she's done some lovely work looking at ultrasound characteristics of these unborn pups. So we can measure brain blood flow, we can measure cardiac output, we can measure all sorts of things that tell us about fetal well-being, and then track that through into their postnatal life. So she's looking at both guinea pigs maintained on a standard diet and standard with creatine. We're also interested in growth restriction. So when the baby just doesn't grow very well in the womb, we know that like preterm, they are also going to grow up to have all sorts of other complications. So the question is then, if we give these mothers creatine, can we correct or prevent some of those long-term problems? And again, for our premies, if during that pregnancy and then early between when they're born and their due date, we supplement with creatine, can we prevent some of this preterm associated morbidity? So that work is underway now, and we're incredibly excited about it. So hopefully in a year's time, we'll have some really, really nice data to share. So that leads me on to really the prem situation in more detail. So that conversation between the mum and her unborn baby. When you're born early, that conversation changes far too early. And suddenly that preterm baby is out in this world without all of those things that mum and her placenta provide and do. So again, if we just think about this in very general terms, time along the bottom, so from conception to term birth over here, there's a whole range of factors of things that are secreted through the placenta or mum provides baby that just basically go up and up and up and up until you're born, and then you're separated from your mum, so you don't have those things anymore, and then you reach this new steady state in postnatal life. If you're born too early, of course, then everything's tracking along, but you suddenly lose all of the things that mum was giving you, and then you find some new steady state. We're not quite sure where that is, but you find that new place. So what we propose is that there's this notion of the preterm deficit. So these are all the things that a fetus would have had, but a preterm baby does not. We think that's going to be really important in trying to figure out how to look after and care for prems better. And there's a whole raft of possible candidates here: omega-3, neurosteroids, creatine, melatonin, IGF-1, and so on. So we know that if we mate our guinea pigs, if we induce preterm birth, and we provide standard supportive care in our guinea pig intensive care unit, when these pups grow up, they have an ADHD type behavior pattern. They've got impaired liver function, they're hypertensive, blood vessels are different, epigenetic profile is different. There's all these things that are different, but actually really mirror what we see in humans born preterm. So we know that this is a fantastic model for us to really get to grips with what's happening in the human prem. So then maybe if we have a targeted therapy that alongside that intensive care, we give these targeted treatments, we could improve outcomes for these children. And not just short-term, but long-term life course improvements. And that's what we're chasing down here. So the first cab off the rank was doing some work, and this guy called Andy Clarkson down in Dunedin. So he's a brilliant neuroscientist, great guy to work with, and he's really interested in a compound called IGF-1, insulin-like growth factor 1. And we know that if you're born preterm, the IGF-1 signaling pathway is altered. So we were really keen to see whether or not, if we could give supplemental IGF-1, whether or not that could correct some of that preterm deficit. So what we did here, so term are in our blue, preterm are in red. We looked at that same open field assessment, and we saw that between term and preterm, there were significant differences in sort of the behavior patterns and also brain growth. But when we treated prems with IGF-1 between when they were born and their due date, we essentially seemed to correct a lot of that pattern, so that our preterm and treated look more like term-born animals, which is really quite exciting. And the same thing here, just looking at the IGF signaling pathway in different ways, we can see quite clearly preterm and term are different, particularly in the girls. But if we treat, then we correct a lot of those differences. And this is looking way down the track in like a childhood equivalency. So the treatment stops when they get to their term due date. And when we look at them sometime later, actually the benefits of that early treatment perseverant, and these animals look and behave much more like a term-born pup. But IGF-1 has a whole bunch of other potential side effects because it is a growth factor and it could do things we don't want in heart and other organ systems. So whilst that's an interesting idea, I think it needs a lot more work before we can progress it. So we started to look around at other options. now that we'd sort of established the proof of concept behind this. And that's where neurosteroids really came to picture. So progesterone, we all think of that as the pregnancy hormone. So we know that mums produce progesterone in higher levels when they're pregnant, and you need that in order to continue and maintain a healthy pregnancy. But what's really interesting is that progesterone gets broken down into this compound allopregnanolone. So as a fetus, this red line here, your allopregnanolone levels just rise and rise and rise. And this corresponds to a period of really active, complex brain development. Then you're born and the levels fall right down. And that's what's supposed to happen. That's a nice, normal term trajectory. So of course, if you're born preterm, you just don't get this, because you're suddenly missing out on all that progesterone from mum. So this allopregnanolone exposure that your brain needs in order to develop normally doesn't happen anymore. So given that the allopregnanolone from both the placenta and from the mother directly have such an important impact on brain development and growth, the question is, well, can we just replace progesterone? Can we do something to capitalize on what should be happening, just simply replace those elements to the baby directly? But of course, that'd be too easy, right? So we tried with progesterone to start off with, but actually there's a whole bunch of steroid byproducts that are not what we need. So that didn't work. So we thought, okay, well, let's give allopregnanolone directly. But again, there's a whole heap of steroid byproducts, has a really short half-life, so that wasn't helpful. But what we did find is there's a synthetic analog, so ganaxolone. It's a medication, a drug that has a long half-life. It's not broken down into anything, and seems to have this really nice, neat, targeted effect exactly where we want it, that could be used to replace the allopregnanolone that our prems are missing. So Julia Shaw, she's now a postdoc over in Newcastle. She did a lot of this work with us, and it's really exciting. So, and again, the Neurological Foundation really supported not just this, but the pilot work around it. So it's pretty cool. So again, our preterm guinea pigs cared for inside the guinea pig intensive care unit, and either just given standard intensive care or intensive care with ganaxolone treatment, remembering that's just between when they were born prem and their term due date. Then they just had standard postnatal care, just boxing on, normal diet, normal environmental enrichment, and then we looked at them in childhood equivalency. And the same thing, we did this open field thing, looking at behaviour, what were they doing, how busy were they, if we give them something interesting to explore and to engage with in their environment, what did they do? In this one, term is green and preterm is blue. And you can see that, the terms just come in, sort of mooch around. The prems, they've got this ADHD thing. So this behavioural characteristic is persistent in all the different ways that we've looked at it. But then if we gave the prems that ganaxolone treatment, suddenly the behaviour again starts to look much more like term-born pup, which is pretty exciting. And then when we look at their behaviour in a bit more detail, again, we can see that the preterm treated with ganaxolone look much more like a healthy term-born pup than a preterm pup. Again, we were pretty excited when we saw these data. It was really, really quite cool. When we actually look at the brain tissue in a bit more detail, look at a thing called myelin, which is the stuff that insulates your brain and helps conduct nerve signals around and about, we saw that, again, preterm and treated looks more like a term than a preterm normal. So where next? This therapy, this is ganaxolone, is a treatment that's already used in a bunch of different medical conditions. So we know that it's a safe medication to use in children. It's not been used in prems, but this is really, really powerful proof of concept data. There's a whole heap of work we still need to do. That study was just done in males, We need to obviously repeat it in males and females. We need to do some dose finding. We need to look at the really long-term or next generation effects even to make sure that before we even think about moving to a human clinical trial, that we know that this is safe and effective. But yeah, we were stoked. We think that it's an excellent start, an excellent place to really try and look at improving outcomes for our babies. And crucially, of course, preterm isn't just a neurological condition. Whilst that is clearly a major facet of all of this, preterm affects everything. It affects your lungs, your heart, blood vessels, kidneys, liver, you name it. But perhaps with this sort of approach of correcting the preterm deficit, we might actually be able to come up with something that supports whole person recovery from preterm. And I think that this very careful, staged approach will give us some really important insights as to how we might go about doing that. So just to summarise, the perinatal period is absolutely fundamental to life course health and well-being. You know, if we get it right for our pregnant women, if we get it right for our babies and our children, we are setting the next generation up for success. And so surely to goodness, that has to be a priority for us all. The big data, so actually understanding within the New Zealand context what preterm means for our children. So we actually understand and can quantify the issues that they face is crucial. We need to have that in order to target so the basic science that we do in the lab to try and address the problems that these kids have. Gestational age matters. You know, 40 weeks is ideal. Anything less than that, we need to be thinking about, is there any choice in that gestation? Because there are potentially going to be implications for the future. And knowing that there are implications, we need to be potentially screening our kids differently, looking at their health and well-being as they grow up, better anticipatory guidance about optimizing well-being, diet, exercise, and so on, to make sure that, you know, our sort of active thinking about promoting well-being doesn't stop when our babies leave NICU. And really using that basic research, basic science to understand and then to treat the preterm deficit, I think has to be a priority. Because unless we have the basic science underpinning all of this, we can't progress in our understanding as to how we can help these children in the future. So I think these novel agents, that notion of the preterm deficit, we've got a window now, we've got a mechanism now to really do something different so that we can help kids, which is obviously what it's all about. Clearly, this work isn't done in isolation. There are many more people even that are on this slide that contribute. And of course, the people that fund us, Neurological Foundation, in particular with some of those bodies of work with the ganaxolone and the creatine studies, have been invaluable. And again, like SJ said, the support through this time of COVID, it's made the world of difference because funding is hard and we need funding in order to do our work. So we're extremely grateful to people that help with that also.